Great, starting everyone. Welcome to May 2024 RVH Grand Rounds. Again, I want to really thank Mitch, the Dean, and Minister for coming Lorenzo, our Psych Talk, who made this all possible. Today we have a great speaker, and we're just chatting with our, geriatrics in all areas of medicine is underappreciated, yet it's probably our main business, the people we take care of. I think that in medical school when I was there, there were some dedicated teachers, but it wasn't as cool as the young overdose stuff, but it's such a huge part of what we do. And we always have room for improvement. And Dr. Bingham is an expert in some of these areas, especially some of the areas like geriatric mental health. So she's a psychiatrist at the North Simcoe, Muskoka, specialized geriatric services and Waypoint Center for Mental Health. Katie gained her degree at Investment School Western, and her psychiatry residency at the University of Toronto. In 2018, she completed a PhD with UT's Institute of Mental Science. She's a clinician investigator and assistant prof with UT, and recent research focused on models of integrated care for older adults with living with complexity. Her clinical work involves treating older adults with mood disorders, dementia, and other psychiatric conditions in hospital, long-term care, and the community. Please welcome Dr. Bingham.
There we go. Can you hear me okay? Wonderful. So thank you so much for that introduction, and thanks for having me. I've certainly collaborated with RVH in my role with North Simcoe Muskoka Specialized Geriatric Services, but I've never actually been here in person before. So it's great to be here and to see everybody, and thanks for joining online as well. So Dr. Martin's already given a great introduction, but just to reiterate, so the title of my talk is Between a Rock and a Hard Place, Antipsychotic Selection for Older Adults. And the reason for that title is I personally don't really know what a hard place is, but I know it's not great. And antipsychotics, when we are using antipsychotics for older adults, there's really no ideal option. These medications are not low risk. They are sort of medications that have their own side effects and challenges, as I'll talk about later. But, we often do need to use them. So that's kind of what I'm hoping to talk about during this talk. I do have Slido if people would like to participate. You can either join, the QR code is sort of variable in how well it works, but you can go to slido.com and enter the key there, the 2038803. So I'll give people a moment to do that. Yeah, most of the kind of questions are specifically around the antipsychotics, but there's a few other ones too, so. Okay, so it looks like people are mostly joining here. So 2038803, as you can see. Okay, so just in terms of disclosures, so I think already mentioned, I'm a staff psychiatrist, recently joined Waypoint from UHN in Toronto, though still living in Toronto for now. Assistant professor at U of T. I have a number of other privileges in various hospitals, kind of reflecting my regional work. My only financial support is through internally through the U of T's Department of Psychiatry. Don't have any involvement with industry. We'll use generic names during the talk and also disclose off-label medication use. Okay, so in terms of specific objectives, I'm hoping that by the end of this talk, you'll be able to describe the evidence for antipsychotic use in older adults with a focus on dementia, discuss its use in special populations, including frailty, stroke, and Parkinsonism, and also select an antipsychotic, or have an approach anyways, to selecting an antipsychotic that's clinically appropriate for specific patient needs. So the first question is, what is an antipsychotic? It might seem obvious, but maybe not quite as straightforward as you might seem. So in terms of a general, understanding of antipsychotics, so they're medications that have a unique efficacy in treating psychosis. So psychosis is delusions, or when people have fixed false beliefs that are obviously not in keeping with reality, or hallucinations. So usually seeing or hearing things that aren't really there. But they are also effective in a number of other different conditions, probably reflecting their pharmacology that involves more than just one receptor. So they're effective in mania, like in bipolar disorder, or mania from other causes, in depression, in maintenance of bipolar disorder, in severe anxiety, potentially obsessive compulsive disorder, tics like you would see in Tourette syndrome, non-specifically in conditions associated with agitation or aggression. We also use them in palliative care, as people might be familiar with, not all of them, but some of them, for nausea, vomiting. They also can be used for intractable or long, or hiccups that are lasting a long time. So they have a lot of different uses. It's not only for, not actually only psychiatric, but mostly. The mechanism is mostly blockade of dopamine within sort of certain target parts of the brain. But not only, as I'll talk about shortly. And they're divided broadly into first versus second generation antipsychotics. So people have probably heard of and used Haldol. That's an older first generation antipsychotic. Or the second generation, also known as atypical antipsychotics, are things that we use more commonly in this day and age. So like risperidone, olanzapine, aripiprazole, clozapine. All right, so just to give you a little bit of an overview about the first versus second generation antipsychotics. So in the older antipsychotics, and in fact, there is an overlap, but that's generally speaking in the older ones, the dopamine, they more strongly act on the dopamine receptors compared to the serotonin receptors, whereas in the second generation antipsychotics, it's the opposite. So they still have dopamine activity, but actually less than, for most of them, less than serotonin activity in general. The first ones also adhere very tightly to the dopamine receptor. So once they're on the receptor, they're stuck there for a while, and their sort of related side effects can persist. And that's also why they have a higher risk of Parkinsonism type symptoms and tardive dyskinesia. The second generation, they either have that looser binding, like quetiapine tends to bind very loosely to coming on and off of the dopamine receptor, well, the D2 receptor specifically, or some of them have a partial agonist effect. So some of them actually potentiate the dopaminergic effects at the dopamine receptor. So that would be examples like aripiprazole or brexpiprazole. For the metabolic side effects, the second generation ones tend to have a higher risk of metabolic side effects. So ones like olanzapine, clozapine, those are big culprits for the metabolic effects, although that may be a little bit less in older adults compared to younger adults. All right, so we'll go, I'm not trying to go back to sort of med school or undergrad or anything like that, but just briefly, a primer on the pharmacology. So the antipsychotics, although dopamine is kind of the target receptor to have the actual antipsychotic effects, as I mentioned before, they have lots of different additional effects, and that's probably at least in part because of their activity at other receptors. So they have anticholinergic effects at the muscarinic receptor. They have alpha adrenergic effects and can cause things like hypotension. They also act as antihistamines, in particular ones like quetiapine, and that can cause some of the sedation and potentially some of the metabolic effects as well. So lots of non-dopamine receptor activity, perhaps actually, well, more than dopamine activity in a lot of the newer medications. Okay, I'm not going to go through this whole table. I'm making my slides available so you can have this for reference. This is just kind of modified from, the good old up to date. And it's just sort of to show that there really is a lot of variability in terms of the type of adverse effects that we can see with these medications. So some have a higher risk of metabolic effects, some have a higher risk of Parkinsonism, some are more sedating, some are more anticholinergic, some have more QTC prolongation. I'm happy to talk more about that afterwards, but that is, just to keep in mind that this can be part of the selection of the antipsychotic, is thinking about what in a particular patient are we most concerned about, and therefore what, or would we be most concerned about from an adverse effect perspective, and therefore what may we want to try to avoid. So, if somebody has a high metabolic risk, for instance, then probably attempt to avoid olanzapine as much as possible, or clozapine if possible. Not always, it's not a blanket, rule, but that's something to consider. Okay. There also are some drug interactions for antipsychotics. So most of them, to be honest, are not overly clinically relevant, but some are. So I won't go through all of them. I'll give this, I'll have this available for reference, but just to highlight a couple ones that can really come up. So olanzapine and clozapine are metabolized through the liver, through the cytochrome 1A2 pathway. And it can actually be induced by tobacco, as people may have heard about. So for instance, if a patient who's taking clozapine or even olanzapine is hospitalized and they stop smoking, their levels can actually increase, and that can potentially lead to toxicity in some cases. So that's something to keep in mind for patients on those medications. And it wouldn't really be improved by nicotine replacement because it's the tobacco like smoke and products itself. It's not the nicotine specifically. A culprit for interactions can also be carbamazepine, as it is for almost everything. We're not using Paxlovid as much now, but that can also be an issue. Like, I don't know if anyone here works in long-term care, but during the pandemic, there was really an issue with Paxlovid being prescribed and then people maybe having to stop their antipsychotics. So we saw that quite a bit. So that was because of a drug interaction. Okay. So there are also pharmacodynamic interactions. So any medication can, that would be when adding another medication that has kind of similar effects worsens the adverse effects of the antipsychotic. So things like benzos or antihistamine can worsen the sedating effects. Medications that are active at the dopamine receptor as well can worsen can increase the risk of like Parkinsonism, for instance, or akathisia. Of course, there can be serotonin-mediated interactions. Doesn't mean we avoid antidepressants, but just have to be mindful that the combination can increase the risk of side effects. And then, of course, there's the big concern about the QTC prolongation. So by that, I'm referring to an increased risk of cardiac arrhythmias by a change in the electrical activity of the heart that's mediated potentially by antipsychotics, as well as a whole host of other medications. So when we combine certain medications with antipsychotics, with some antipsychotics, the risk can be increased of a cardiac arrhythmia. This is particularly relevant for some antidepressants, for some antibiotics as well. So I did indicate here there is a helpful list that I've been able to use at times, compiled by credible meds, just for reference. So it doesn't mean that we have to stop an antipsychotic if somebody started on another QTC prolonging agent, but if we may decide to do that in somebody who's very high risk, or we may choose to monitor with serial EKGs. Okay, so this is where I have some Slido interaction. It'll pop up in a moment here. So I have a few kind of cases, and I don't expect, there may be multiple correct answers or not necessarily one right answer, but this is just to kind of illustrate some of the clinical points that I'll get into. So the first case is a man, 78, with moderate Alzheimer's disease, presenting with more severe behavioral symptoms of dementia, so actual psychosis, physically expressive behavior, so symptoms that we would want to treat, probably using both a behavioral approach and a medication approach. In this case, the medical history is only notable for hypertension and diabetes, and only taking metformin, amlodipine, no allergies. So let me make sure this works here. Yep, it should be working. So which medication might you use? You can go ahead and just see what you think. Okay, we have risperidone so far. It's a good contender. None of the above. That's always never a bad answer in older adults. I'll give people a little bit more here. Okay, so yeah, so it's kind of moving around, but risperidone's a strong contender. Some people think quetiapine's a good option, aripiprazole. There are some people who are very cautious and would not use any of these medications in this patient. So yeah, so we'll get to it. I mean, there's nothing here that's like a completely wrong answer, but some answers are better than others. Okay, so next case. This is an 80-year-old woman with Parkinson's dementia presenting with distressing visual hallucinations and associated delusions. No kind of major contributory medical history, taking Sinemet and pantoprazole. So Sinemet is a pro-dopaminergic medication. So it increases dopamine in the brain. So it can also contribute to psychosis in and of itself, just to highlight that fact. So what might you use here if you were going to use, what medication might you consider in this particular case? Okay. Got a strong contender in aripiprazole, like a horse race or something. Okay, so yeah, so aripiprazole, quetiapine, some people who are still cautious and would prefer not to use any of these antipsychotics, and then maybe a couple of 1 or 2 votes for risperidone. We'll get to it. Last case, so this is an 85-year-old woman with vascular dementia, so has had a stroke before, as I illustrated below, presenting with anxiety and agitation related mostly to disorientation and separation from spouse or family. No previous medication trials for behavioral symptoms, history of sort of multiple vascular risk factors, and then current medications, aspirin.
Get some of those once in a while.
Oh, I know, tell me, yes, for sure. So yes, clopidogrel, amlodipine, and atorvastatin. So which medication in this case, if any, might you consider? I've thrown some different ones in, well, one different one in there. Oh, someone likes lorazepam, okay. Okay, we're getting some votes for quetiapine. Yep. Nobody's going for risperidone. Okay, very good. So quetiapine is a strong contender. So, all right, good. Thanks very much for participating. So we'll get back to the kind of the questions in a bit, but just to talk about some of the evidence for antipsychotic use. And I'm going to focus on dementia because the evidence for use of antipsychotics, for instance, for like a schizophrenia or treatment-resistant depression is not that different from in younger adults. But when it comes to their use in dementia, that's where it's sort of a unique evidence base. Okay. So in terms of efficacy, first of all, when we talk about efficacy, we're talking about their efficacy or effectiveness in reducing neuropsychiatric symptoms in dementia, particularly like more severe agitation, aggression. We don't really prefer to use that word. We usually say like expressive behaviors or neuropsychiatric symptoms, as well as sort of more severe agitation. The evidence at this point, there actually was, I put it as a reference, but there's been a good guideline that has just been released earlier, like a month or 2 ago, from the Canadian Coalition for Seniors Mental Health, which really summarizes a lot of this evidence well. But generally speaking, all of the risperidone, aripiprazole, a newer partial agonist antipsychotic, brexpiprazole, so a cousin of aripiprazole, maybe a sibling, and quetiapine all show roughly equivalent modest evidence in reducing sort of agitation, aggression, psychosis in dementia. Interestingly, olanzapine has not specifically been shown to be more effective than placebo, at least based on meta-analysis, and it may have more adverse effects as well. So this, to be honest, did used to be one of my go-tos in a lot of cases, and I think I've, adjusted my practice a bit based on this. But any of those 4, or with the exception that quetiapine, it really does have to be at higher doses that it's equally effective. At the lower doses we tend to use in dementia, it is probably not as effective. So the risperidone, aripiprazole, and brexpiprazole seem to have roughly equivalent evidence. And they also may be more effective for patients who have more severe symptoms. So if somebody has severe agitation, physically responsive behaviors, actual psychosis, not just sort of non-specific agitation, their benefit risk ratio is different than somebody who has less severe symptoms. Also, interestingly, may be more effective for patients in long-term care versus outpatients, and that's probably related, I would imagine, to the severity of the symptoms as well. Okay, however, I guess this is where the title comes in. There are a number of potential adverse effects as well. And this was behind the push to really try to reduce the use of antipsychotics in long-term care because they do have a lot of potential adverse effects, unfortunately. So things like falls, hypotension, sedation, even cognitive dysfunction may actually accelerate cognitive decline by up to a year based on estimates. Of course, Parkinsonism, akathisia or restlessness, tardive dyskinesia, which is sort of a later onset movement disorder that is related often to antipsychotic use. Also a number of metabolic abnormalities. I spoke about the cardiac risk of aspiration pneumonia, risk of potential cerebrovascular events, and even death, with olanzapine potentially being the biggest culprit. So I've kind of illustrated that here. If we were to treat 100 patients with dementia with antipsychotics, the versus if you were comparing that to dementia patients who are not treated with antipsychotics, there would be 1 excess death in the antipsychotic group, 2 excess cerebrovascular events. So not necessarily an actual stroke, but non-specific cerebrovascular events, maybe a TIA, maybe thought to be a stroke, but wasn't seen on imaging, that kind of thing. And the number needed to treat is about 10 to 20 patients will benefit. So it's not a really, high number needed to treat, but it's not substantial, it's not 1 in 4 or something like that. So it illustrates that they're not the perfect medication, unfortunately. And, would ideally have some better options for patients, but this is what we have, in some patients do significantly benefit. As I mentioned before, there is that kind of subgroup of people who really benefit quite a bit. Okay, so in terms of the approach to prescribing and deprescribing, this is in dementia specifically. So evaluate for response at 3 to 4 weeks of optimized dose. Can't really make a firm conclusion until then. But then also consider tapering after 4 to 6 months. This is again in dementia, not if somebody has a history of schizophrenia or something. The risk, of course, is of symptom worsening. And so the way that I would, sort of consider that is like, how severe were the symptoms initially? How long have they had them before? Did they have a good response to the antipsychotics? Like, this can kind of help to decide if we want to try to stop the medication. Okay, so this is the part where I have included more for reference, but I'll kind of go over it a little bit here. I do have a poll, that's right. So which antipsychotics are actually approved by Health Canada for treating dementia with behavioral symptoms? And you can choose more than one. None of the above, good get. Spiridone, aripiprazole, oxypiprazole. Honestly, I would have I have to look this up all the time. So this is more just to get the conversation going. I don't expect people to have this at the top of their minds. Okay. All right, very good. So people have the idea, but it's not exactly what you think. So I will talk about it. Risperidone, yes, it is approved by Health Canada and was until recently the only antipsychotic that was approved for management of neuropsychiatric symptoms of dementia, specifically Alzheimer's, because really all the studies have been done in either Alzheimer's or maybe Alzheimer's mixed vascular dementia. So it is Health Canada approved for that indication, but I would suggest to avoid its use in Parkinson's or Lewy body dementia. So I had the case earlier of the patient with Parkinson's dementia who had psychosis. So in that case, we would not use risperidone as a first, almost ever, I would say. Never say never, but I would tend to really avoid risperidone in that setting because it binds very strongly to the dopamine receptor, even though it's a second generation antipsychotic, and it can really worsen Parkinsonism. And it also would oppose the effect of the Sinemet. I won't go over all of the dosing. I've sort of included that here for reference. But the other thing to keep in mind that can be useful about risperidone and that can help with antipsychotic selection is that it is also available as a liquid formulation, which can be helpful for patients with dementia who may either need cold administration or may have difficulty with swallowing pills, that kind of thing. So it's a good option. It's not available in an immediate release injection, so it can't be used like as needed for severe agitation in a needle form. There is a long-acting injectable form of it that people may have seen used for schizophrenia, for instance, but we don't typically recommend that for patients with dementia because of the high side effect risk. Okay, so aripiprazole actually is not approved by Health Canada, probably just because it was not studied specifically for the drug company didn't submit it for that indication. I would imagine is the reason why, because it does have evidence for its use. In this case, people had indicated they might use aripiprazole in Parkinson's, and that's not wrong. It can be used, but it does increase the risk of Parkinsonism as well, just because even though it is a partial agonist, it still binds fairly strongly to the dopamine receptor, and there still is a risk of Parkinsonism and worsening Parkinson's symptoms. So it can be used, but used with caution in that setting. It doesn't have any other immediate release formulations. It also is available as a monthly injection, but again, not typically recommended for dementia. So brexpiprazole is relatively new, and it's aripiprazole's sibling, as you can imagine. It is actually Health Canada approved more recently for management of agitation, specifically in Alzheimer's. So it's one of the two that are approved. Again, I think because of marketing probably, but it does have evidence as well. Same thing, so caution in the setting of Parkinson's should really be reserved for severe symptoms only. Not available in any other formulations either. So it really is only available as a pill. So quetiapine is off-label use. There's no Health Canada approval for its use in dementia, but it actually would be considered the first-line option for patients with Parkinson's or Lewy bodies. So it does not bind tightly at all to the dopamine receptor. It doesn't really get that kind of antipsychotic effect until higher doses, although it can be effective at lower, relatively more so at lower doses in Parkinson's. So, you know, the reason the way that we know that it's not a high potency antipsychotic is the dosing. So instead of a dose of like 1 milligram, 2 milligrams for risperidone, to get an antipsychotic effect, we usually need like 300, 400, etc. It has other effects at lower doses, but not an antipsychotic effect really. So that being said, I mean, it can be helpful because it has that sedating property. So sometimes for patients who would really benefit from that, it can be a really good option. But I wouldn't typically use it for people who really need that antipsychotic effect, like have severe symptoms, you know, severe agitation, physically responsive behavior, because you do need to get up to such high doses, and then you get into the risk of side effects. So it's not available in any other immediate acting formulations, but the tablets can be crushed, which we often do. There is an extended release formulation that's used very commonly in mood disorders, for instance. We don't use it as frequently in dementia. Doesn't mean you can't, but it's just not been as well studied. If you do want to use the XR formulation, we would suggest giving it about maybe 3 to 4 hours before bedtime, because that's when the sedating effect tends to kick in because of the immediate release factor. Okay, so olanzapine, it's really falling from grace here because of some of the recent evidence, also off-label use. The guidance now suggests that it really should only be used in the short term or for patients who really just haven't responded to other options. I have also used it sometimes in Parkinson's with severe symptoms, just because it's mid potency, so it's not as risky as risperidone in that setting. The benefit of it is it's available in different formulations. So there is a dissolvable form, that the olanzapine Zydis, or well, that's the brand name. And it also is available as an immediate release injection too. So it's good for very acute agitation where we might need to use a needle as opposed to a pill. And in some settings that would be preferable over Haldol, for instance. Okay. So I didn't choose to go over the first generation antipsychotics just because we really don't use them as commonly, like Haldol, for instance. We do use as needed commonly, but not regularly. But I'm happy to answer any questions about them. So in terms of special populations, so first I'll talk about stroke and vascular dementia. So you might remember that was one of the cases. And that really, this is a high risk population. We know that there's an increased risk of stroke in general in patients with dementia. And the highest risk is probably in the first 60 days after starting the medication, which does kind of suggest it's a true medication effect. And the risk is likely higher in vascular dementia. Now, sometimes people are just sort of diagnosed with vascular dementia because they have some vascular risk factors. That may be lower risk than somebody who actually has had a stroke before. So I really consider the risk to be high in somebody who's had a previous actual stroke before. Unfortunately, this risk is likely a class effect. We don't know, but likely antipsychotics increase the risk. There's lots of potential mechanisms: orthostatic hypotension, tachycardia, reduced mobility, and sedation leading to thrombus formation. So it's likely multifactorial. But the implications would be that we really have to be cautious in using antipsychotics in patients with a stroke history. And if they are indicated, then just sort of optimizing cerebrovascular risk factors, monitoring vitals, metabolic parameters, encouraging mobility if possible. So I had referenced a case earlier of a patient with vascular dementia, and in that case, the patient had fairly mild behavioral symptoms, and people were thinking quetiapine could be an option for treatment, which I agree, I think it could be. But typically in a patient like that, I actually would not use antipsychotics, at least not first line. We would start with either behavioral strategies or with an antidepressant, not go straight to antipsychotics in general, just because of this risk. Okay, I think I've talked a fair amount about Parkinson's already, but really this is another high-risk population. And it's not just that they can get worsening Parkinsonism, they can also get worsening of their entire presentation, including cognitive worsening, especially in Lewy bodies. So that's, really something to really consider, and using antipsychotics as last resort or for more severe symptoms. So there's other options, even for somebody who is acutely agitated. I often will use like benzos, which is rare for a geriatric psychiatrist, but I would use them preferably over Haldol, for instance, in a patient with Parkinson's. And again, the quetiapine is really the first line, but there are other options. So aripiprazole is another option, olanzapine is another option. Clozapine really is what works best in this patient group, but of course that has its own risk factors. It is a high-risk medication, so that usually is a referral to psychiatry when considering that. And really to avoid the higher potency antipsychotics like risperidone and Haldol. Okay, so I just have a bit of an approach for factors to consider when selecting an antipsychotic. So like I mentioned, risperidone, olanzapine, well, olanzapine less so now, to be honest. So really risperidone, aripiprazole, brexpiprazole, higher dose quetiapine all have similar evidence for efficacy. Medication selection really depends on individual patient factors. So I have an algorithm here just to sort of think about. So when I'm selecting an initial antipsychotic, I first think, and this is more in the setting of dementia with behavioral symptoms. So first think, okay, do they have Parkinson's or Lewy body? If they do, then really it's quetiapine that is the best option to at least to start with. If they don't, then I think, well, how severe are the symptoms? Do they have, high risk symptoms? Do they have actual psychosis, or is it, sort of lower risk symptoms that may not require like immediate management with a more potent antipsychotic? So if the symptoms are more severe and high risk, then really any of the three, risperidone, aripiprazole, or brexpiprazole, have evidence for them. And that's when you might want to consider like some of the other factors I talked about. And other factors might include even, the patient's past history of response to the medications, the formulation available. And I would also include, I wouldn't discount clinician experience. So, for me, I do tend, to be honest, to use risperidone a fair amount because it's what I have had the most experience with and know how to use and know what to expect. So I think that's an important factor to think about too. Not that we can't get more experience, but it's better, I think, to be really familiar with a few medications than to be kind of using a bunch of different medications in this setting anyways. The other thing I think about is, do they have a high cardiac risk? So have they had a relatively recent MI? Do they have heart failure and structural heart disease? And in that case, I would be thinking about, are they at risk for that QTC prolongation and arrhythmia, which can be higher risk with some antipsychotics more than others. And if they are, then aripiprazole or brexpiprazole might be a good choice because they seem to have less of that risk. It's not, definite, but they do seem to have less. And quetiapine does actually have a risk of prolonging QTC, especially at relatively higher doses. So I'm not saying I always avoid it, but it would be a consideration. And then I think, okay, would they benefit from the sleep promoting effects? And if they would, and they're relatively low risk cardiac wise, then quetiapine is probably a good option. If not, then really any of them are fine. And again, that is if we are going to use an antipsychotic. There's always the option of, especially in the setting of a lower risk symptoms, we should really be thinking of other strategies first, but this is by the time we've gotten to that point. Okay. Oh, okay, so that's the talk actually. I did want to just, before we take questions, I just wanted to take a moment. People might have got this in their email already, and this at the moment is really aimed for physician and nurse practitioners. The North Simcoe Muskoka Specialized Geriatric Service, we used to, I don't know if anyone remembers, but we used to host an evening in geriatrics where it would be CME on various topics relevant to geriatrics. It really is aimed mostly at primary care, but anyone is certainly welcome to attend. And we'll have 2 talks. It's on June 18th in Orillia. The first talk will be by me, and it's about an approach to diagnosing the actual etiology of neurocognitive disorders or dementia in primary care. So do they have Alzheimer's, vascular dementia, Parkinson's, etc.? And the second is actually by Dr. Jennifer Watt, who is one of the developers of the guidelines that I mentioned, the guidelines around how to treat behavioral and psychological symptoms of dementia. That was recently put out, so I think it will be a good event. If people are interested, I have the QR code in the link, and we also have sent out an email, I think, to the staff. So there you go. So happy to see people there, and I will stop now and take any questions. I don't know how we do the virtual usually, but today.
That's good. Leaving time for questions is a good idea. Any questions? I got for any questions for sir? Okay. So with the QT prolongation, what's the recommendation for screening ECGs and to do that when you're in dose?
Yes, so I wouldn't say there's really excellent evidence in terms of an actual guideline. It's sort of based on clinical experience. So we don't screen everybody for QTC prolongation when we're initiating antipsychotics, because then, that's not necessarily choosing very wisely. Like, not everybody is at high risk of QTC prolongation. Not everybody who may have some QTC prolongation is going to have an arrhythmia. So for people who are at high risk, so people who have had a known history, for instance, of arrhythmias, who have heart disease already, then typically, well, the first thing I would think about is, can I select an antipsychotic that doesn't have that risk, like aripiprazole? It really doesn't. In that case, I wouldn't bother. Look at an old EKG maybe I would do that just to be on the safe side. But if we do have to use like quetiapine, for instance, risperidone, olanzapine, they all have some risk. Then if they've had an EKG done in the past, like 6 to 12 months, provided their health's been generally stable, I'll look at that and make sure there's no substantial QTC prolongation. And then the suggested guidance would be to do an EKG after the medication's been started within, a few weeks, a month or so. There's not a specific amount of time. And then after every dose change, some people are extremely cautious and will do periodic EKGs like every 6 to 12 months after that. That's, to be honest, not my practice unless there's, like a change in their health, like in their cardiac risk status, that kind of thing. But that would be kind of the general guidance, if that makes sense.
Absolutely. I think that I found my practice around more than one field on the Muskoka.
Oh, yes.
And
yeah.
We have really good pharmacists who hey, there's not another QT prolongation.
Oh, yes, that's right. Well, that's the other part of it. If you are putting them, if they have other risk factors too, like they're on another QTC prolonging agent, or if you're using higher than suggested doses, like for instance, escitalopram has a risk of QTC prolongation at higher doses, like above 10 for older adults, 20 for younger adults, then I would do an EKG as well. So that definitely can always talk to the pharmacist. That's a good resource.
When you do your practice, you've got an older individual who's had this dementia, and the behaviors are quite aggressive, and you're looking at this patient, you're saying, yeah, I need to do something fast, like get this under control. What's your go-to then? So
that is when I personally go to risperidone. If I really need a quick, result, and that is often for hospitalized patients, as you can imagine. If they're in the community, doesn't matter, same thing, I would still use risperidone. But often the case if they're hospitalized for behavioral symptoms is because they're fairly severe. And that's when risperidone has the longest use, and I don't arguably the best evidence. You wouldn't be wrong to use aripiprazole or brexpiprazole either, but risperidone, I just sort of know it usually works. It's one I have good experience with. That would usually be my go-to. If you need an intramuscular medication to acutely to settle things down, then olanzapine can be a good option for that. I still will use Haldol, but just be cautious about the dosing. So don't use 5 milligrams like we would in younger agitated adults. You would use 1 milligram, 2 milligrams. So just be cautious about that.
If you are using those medications, you'll see use Haldol. and I'm going to date myself, but we used to use a lot of beef.
Yes.
So do you combine it with the beef
No.
Benadryl, Halo 5, Benadryl 50, and 2 Valium. So do you combine your Halo with a?
The B, no, we don't use the B in Benadryl in older adults. I think it is still sometimes used in younger adults. Usually it would just be the 5 and 2, so Haldol and lorazepam in younger adults. In older adults, if it's very severe agitation, I wouldn't use 5 and 2 though. I would use maybe like 1 to 2 and 0.5 to 1. So it's not never used, that combination, but often I would, even in older adults, I would often just start with 1. And in that case, I would usually select Haldol unless they have Parkinson's, then that's a no-go. But if they don't, then I would select Haldol and just not even use the lorazepam and see if I need it.
Whereas the landscape, the actual and AIDS mortality.
Yes.
It's a weird.
Yes. So if you use IM olanzapine, don't use benzos with it. Yes, it's supposed to be within 4 hours. I believe it's 4, maybe it's 6. I think it's 4. I always just say to keep it off the MAR because you just don't want to risk it. Like, why even combine the two? Just use olanzapine by itself.
Do you ever see those you're talking about here? You ever see like akathisia? And how do you see that? If you think that, actually, this is a sign of the actual class.
Yes. So yes, we definitely see it. I would say less in older adults, to be honest, than in younger adults. But aripiprazole can be a culprit. So can brexpiprazole, risperidone can definitely be. They all can really, but the high potency may be a bit more than the other ones. The first step is to either reduce the dose or, if it's really bothersome, to change the medication. You can use benzos very temporarily to try to address that effect. But in older adults, you just have to be very cautious. Like, honestly, if I see that restlessness, I'll often just switch to a different medication rather than actually treating it as a side effect, especially in the dementia setting. If it's somebody who has, treatment-resistant depression and I really want to use aripiprazole, then I would be more likely to use a benzo to bridge as the akathisia hopefully improves.
Question?
Antipsychotic cheaper.
Yep. Sure.
Like the long-term care ALC dementia patient.
Yeah, so really it is, as I mentioned, it is best practice to consider in the first place to do a taper. I know a lot of homes have rounds where they kind of review people who have been on antipsychotics and is it time to taper? Usually it's that 4 to 6 month time point where we consider it. Are you thinking about like how to actually do the taper? Oh, sure. Okay. So in terms of, so people that I would not attempt to taper on would be people who do have a psychiatric history of like schizophrenia, bipolar disorder, etc. So it doesn't go away until they're kind of at the very end stage, like of dementia, it doesn't go away. And so they really should never be, and I think there's a way of coding that in long-term care so that they're not considered, there should be, so they're not considered for a taper. The other group, I would be very reluctant to consider a taper at that time point, maybe after more like a year or two, would be people who had very severe symptoms, like where there was a critical incident, like physical aggression, somebody was injured, like that severe psychosis, that kind of thing. So for me personally, like by the time I see those people, usually it is more severe, and then I'm reluctant to do a taper that quickly. I might wait a bit longer. The other group that I would not consider a taper would be somebody who we've tried to taper before and it didn't work. So you may try it again, like once their dementia progresses more. But if there hasn't been really anything that's changed in the dementia, then I wouldn't consider a taper at that time point. And I do it slowly, like there's no rush, right? So you can like reduce it every month. Like if they're on risperidone, 1 milligram reduced to 0.75 after 2 to 4 weeks, and just go like very slowly, because the risk would of course be reemergence of the target symptoms.
One more question for you. Who should you refer to? At what point does it leave the primary care and you refer to specialists?
Yes, it's a good question. I think it depends. I mean, it does, of course, depend on the setting and the individual physician's comfort level with these medications. But I think a lot of family physicians, especially these days, are very comfortable with these medications. So what I would suggest is, once you've tried, so let's say you've tried one antipsychotic medication, like you all sort of suggested risperidone might be a good option for that first case of the patient with more severe symptoms, provided they, weren't even if they were hospitalized and you were following them as a hospitalist. Risperidone's always risperidone's a good option. Let's say we tried that and that was not effective or it was making things worse. Then honestly, I think because of the complexity of this population, like that's a time when it's certainly appropriate to refer to us. Certainly once you tried 2 options, like that would definitely be a good time to refer to us. The other time would be if there's a lot of complexity. So like right away. So somebody, for instance, with like Parkinson's, bipolar disorder, or even somebody with like Lewy body, for instance, that would be a reason, especially if like you tried quetiapine and that didn't work, that would be a reason to refer to psychiatry as well. Or, I mean, it is any time that somebody's like has very severe symptoms as well, like there was like a very high risk, like an injury, that kind of thing, then that's also, I think, an appropriate time to refer.
How do we refer to you?
Oh, I should have put it up. So you can just refer through, so you see the nsmsgs.ca, that's where our referral form is. We cover the whole North Simcoe Muskoka region, so including Barrie. It's not me and Barrie, it's Jeff Daniel covers Barrie, but that would be, that's just through our website. You just can refer to us through there. In the hospital, RVH, unfortunately, we don't yet have a psychiatry presence. We do have good geriatric medicine physicians who work here, but we're hoping to, well, psychiatry, I shouldn't say we don't psychiatry, we don't geriatric psychiatry. So we're hoping to change that, and that hasn't, stay tuned for that. That's not something that's immediate, in the immediate future.
And what's the age cutoff?
So the age cutoff is for dementia, there's no age cutoff. So if they have, if they're 40 and they have dementia, probably refer to one of the Toronto centers. But if they're, sort of dementia with agitation, then or dementia in general, there's no age cutoff. If it's an older adult, just in general with psychiatric issues, our mandate is to serve frail older adults, typically age 65 and up. But, we're not hard and fast. Like if they're 62 and have a lot of frailty, certainly if they have cognitive impairment, then we would consider that referral as well.
Also, they get more information when we post at the top. That's okay. We'll have referral.
Oh yeah, I can send to Mitch. I can send that. I'll put it as a slide
and,
so that you guys have that.
The talk of the evening, we'll make sure to send it to Flo as well.
Oh yes, excellent. That'd be great. Yeah.
And that's be there. Obviously, the big provider of benefit. Well, your slide was awesome. I'm going to reference your slide later because that flow chart is just a really nice way of kind of thinking through your choices. So thanks so much. Any other questions for Dr.
Somebody there. Oh, sure. Yeah, that's a good idea. Yeah.
Good question. My husband is right.
That's a great idea. I was thinking about that too, but I was like, I'll try to reference them, but let's go back to the actual cases themselves. So, okay. Whoop. No, farther. Okay. So this was the first fellow who has sort of classic Alzheimer's with more severe agitation. This is where I personally would usually go to risperidone, but this is an evidence-based talk, of course. Aripiprazole and brexpiprazole have equivalent evidence in this setting. So really you couldn't go wrong with any of those 3. I would then start to use other factors that I talked about to kind of decide between those 3 medications, or just, patient like shared decision making. So really any of those 3 would be appropriate. And I think people chose aripiprazole as well. Risperidone was the primary choice, which is, I would say, correct. Quetiapine isn't wrong, and it could be worth a try depending on the patient situation, but you may have to just get up to high doses, which can take a while. It can cause a lot of orthostatic hypotension and sedation. So it would really be the 3 that I mentioned. For this person with Parkinson's, this is where quetiapine would have the best evidence. Aripiprazole isn't wrong either. Like that could be used as well, just cautiously. Risperidone, I would not use. At least I never say never, but I would refer to psychiatry if that was being considered. Okay, so vascular dementia. This was a lady with vascular dementia with sort of less severe symptoms of behavioral symptoms. People were thinking quetiapine, which I think is, again, that's not a wrong answer. Like they're sort of choosing a lower potency antipsychotic, maybe using doses of like 25 milligrams, not 200 milligrams. So that definitely could be appropriate. I personally would not use any antipsychotic at this juncture just because she hasn't tried anything else yet. But I agree that quetiapine would be a good next step for this kind of clinical situation. The others would be a lot lower line. So that's, yeah, hope that was a great idea. Thank you.
comment.
It wasn't like a right or wrong, it was just to, generate discussion.
Any other questions for Dr. Gunn? All right, again, I want to thank you for coming. This is a very useful and insightful talk, and we appreciate your time, and have a great day.
Thanks very much. Thanks for having me.